disposable drills. Disposable drills use I promise I'm using. But not in the institute, they are stingy. That's the reason why I'm not accepted by so many implant manufacturing companies, because I'm fastened to that. Because I also work with Noble Pharma, not Noble Biotech. It's a parent company of Dynamaxis. So I can very well talk about the firm of that also. Now, these two are very, very friendly in nature because they have good vascularity, good cortical bone to support the load carrying implant. But again, this is a mimosa pudica, that is touch me not. So touch me. Yeah, we got to be very careful with that. So how we are going to manage all these cases? Because we are not going to say, I will do only this, I will do only that. Because the Indian population, they are very diversified unlike the Western. Western people, we can do a crown preparation by standing out into the patient's mouth. So big is the crowd, but not the Indian population. You would see Indian population so tall but a small dentition. So we are diversified. We have the beautiful people in the planet to work upon. You know, you get a lot of experience. You get to see only a monologue thing in all the Westerners, a huge mouth and huge jaw, but not the Indian population. So in the forthcoming slides, I will be explaining you how to manage all these clinical conditions. So this is about the quality of the bone, then the resorption pattern. So it is immediately after the extraction, a mild, moderate resorption, a knife edge, severe resorption, and resorption just leaving the basal bone. So which will be the favorable one? B and C. A very favorable condition, which you can be assessing the same with the CBCT. Then comes, sometimes you have a good quality, clinical to see good amount of bone. But these patients would have lost all the teeth because of the periodontal problem. When you have periodontal problem, you can close your eyes and that gram-negative bacteria are still persist within the cavity. So they always go for the resorption of the bone. So we wait. If you have a case who had lost all this natural teeth because of the periodontal problem, do not ever go for immediate placement of the implant. I repeat it again, chronic destructive periodontal patient, do not go for an immediate placement of the implant because you are not sure that you have eliminated all the remnants that are seen within the extracted site. Wait for at least 6 weeks minimum, then you place the implant, and those implants cannot be loaded immediately. Understand? So these are the things that can be assessed through your radiogram. That is the first and foremost important thing. Now, hospital will, if the patient has got 100,000 or 250 hospital loadings, that means he's got a solid bone. It's got a solid bone. So immediately what you get in your mind is drilling difficulty, high torque value, generation of high heat is high, and you needed to be very careful when you're dealing with this material because of absence of vascularity. Then comes 850 to 1250, friendly zone. 350 to 850, again a beautiful condition because it's a D3 bone where you have a 1 mm to 2 mm of thick cortical plate with a good trabecular pattern. And finally, D4, 150 to 350. They are the mimosa pudica, the sensitive bone normally seen in the patient with the chronic destructive periodontitis and posterior maxilla. So now you got to know, you have the clue who are the patient having, what are the qualities of bone in the mouth. The next one here. Now, this is a normal plan. We do OPG, the present day CBCT, where the software has got multiple library of various implant system. You can superimpose, then you can go for the placement. It can include the dimension, the length, the diameter, everything, it gives you the clue. And of course, after the placement of the implant, IOP. So this is the sequence. OPG, followed by CBCT, treatment planning. After the placement of implant, again, you don't have to go for a CBCT or anything. It is good enough if you go for an IOP to assess how goodly you are placed. Then, after the placement of the processes, again, a simple IOPA or RDGs, good enough. Now, okay, now the present CBCT advancement, we get the contrast and everything where you can superimpose the implant exactly the way you want. The sinus flow, and all those things. Now, always we have the concept, implant. But if you know your anatomy, you can give a mild angulation, utilize the palatal bone, or you can bypass the mandibular canal also, you can place the implant. And availability of the precise prosthodontic component from all the systems that we have available today, we can very well manage the patient. Clear? Now, quality of the bone. So, here you should know, the quality of the bone is good in the anterior mandible. But as we all know, even in the prosthodontic days, or even in the undergraduate level, we know, the maxilla has got always the poor quality of the bone, but the mandible's got the good quality of the bone because of the cortical nature. So anterior maxilla has got the better tolerance, mandible got the better tolerance level. Then we switch over to the maxilla, the posterior mandible and the posterior maxilla. Between the genders, the women, they have a poor, well, I will not say poor, they are softer in nature. And post-menopausal women, of course, because of the estrogen hormonal imbalance, there is a change in the quality of the bone. Bone quality consultation. Now, you have seeing all the patients that you have come to a conclusion, this patient has got a particular type of bone. Suppose if the patient does have only the type 1 bone, where it is the thick cortical bone, what is the surgical procedure? A copious irrigation as cortical bone is more sensitive. When I say more sensitive, you have a torque value of 35 newtons. Increase the torque slowly. Don't go up to the highest torque because heat generation will break down the alkaline phosphatase. Eventually go for the necrosis of the bone. Avoid doing that. Avoid clogging during drilling procedure. Clogging after, don't do that. Do the pumping action. Make sure you remove the bone chips away from the surgical tip. Thereby, you will not create resistance as you do the drilling or the osteotomy preparation. Avoid usage of blunt drills. Use disposable drills. Are we doing this? In case of threaded implant, tapping should be done to place them. Tapping means threading the implant side. Where we do with the, not with the titanium, but with the stainless steel drill with the RPM of 20. Yeah? Otherwise, for a thick cortical bone, the RPM can go up to 1,500. But make sure it is falling within 1,900. Do not exceed beyond that. Rotational stability is required. What do you mean by rotational stability? When you do the final placement of the implant should not rotate. Implant should not rotate. That means there is a definite gap exists between the bone wall to the implant. Do not get panic. Do not get panic. For example, you want to place an implant of 3.75 millimeter, but after the placement, because of some variation, you have overdone it. Do not place 3.75. You take a 4 millimeter implant and place it. You have a good rotational stability. So this is how you can manage the implant. So the 4 millimeter implant becomes the rescue implant. Is that clear? Am I clear in this? Then avoid summer texturing. I'll explain about this when I come to the maxilla. What is the summer technique? Okay, type 2 and type 3 bone, they are very friendly in nature. We can do a classical procedure. Type 4 bone. Now, this is I call as a Mimosa pudica or Torta churita. So how are you going to deal with this? Final drilling should be 0.6 to 1.2 mm smaller than the implant diameter. Now what do you mean by that? If I'm using a 3.75 millimeter diameter implant, I stop my final drilling with 2.85. In this case, you are doing an under preparation. Using the elasticity of the bone, we are placing the implant to get the primary stability. Am I clear? Am I clear? So unnecessary widening of the osteotomy site is avoided by doing an under preparation. So we are believing more in the elasticity nature of the bone, not with your technical skill. So again we are living within the physiologic tolerance of the patient.